is it's going to be a real patient. The team that's taking care of this patient is going to be a WAB, Feba, empathy. The idea is not. Well, the idea here is not so much as getting at the right answer. The whole point of these CPS cases, because we have plenty of lectures on resuscitation and patients that are acutely sick that we have to manage. I think we don't pay enough attention to what's going on with the patient, what's the final diagnosis, what's the inciting reason why the patient got sick. And so we'll talk about a few things that you guys do in between to stabilize the patient, thought process and things like that. But the idea here is to get an idea of what's going on in your guys' head, what's your guys' thought process, so that all of us can learn from you guys. Once again, it's not about getting the right answer. Each of you guys have your own way to manage these patients. There's no right or wrong answer. I mean, there is some wrong things you can do, but the idea is just simply to get inside your brain, and then along the way, I'll throw in some pros. Everyone else, if you guys have things that you guys would like to throw in, I'll have the teams in front of me so that way, if you guys have a good idea, I'll throw them in. But the idea is that you guys solve the case together. You guys are a real team about to go see this consult. Cases can present in the form of rapids, consults, or admissions, or codes.
Can you minimize that thing? Focus on content.
You can say it, it's fine. They can't see you.
It's kind of small, man.
It'll change in a second.
Okay.
What? All right, so the consult is a 64-year-old. You get a consult by the internal medicine team that they have a 64-year-old that's presented with 2 weeks of worsening dyspnea. They were admitted 2 days ago, but now they're having increased O2 requirements. They think the patient might need to be intubated because now they're maxed on high flow nasal cannula. So you're somewhere up on 4, this patient's somewhere away to east. You're about to go ahead to go see the patient. And you're obviously getting ready. You're going through differentials in your head. What are you thinking of as possible differentials for what might be on this patient? And how might you, once you get there, approach the patient? Have you guys go first. I mean, if you have anything else that you think you want to add to what they say, then you can do that.
I know what comes to my brain.
Yeah. Or I guess how are you approaching this patient in your head? Besides, hopefully it's not just walking into the room and you're like, all right, what happens, happens.
Yeah.
Well, it's a really broad differential,
Yeah,
just what we're seeing there.
Yeah.
If we're asking dyspnea, it could be pulmonary etiology, it could be respiratory etiology, it could be neuroetiology, cardiac, we don't know.
Yeah. And so you know that, obviously with any patient, you're going to go in and start taking like ABCs, IVO2 monitor.
That's what I was doing.
Every time, right?
What he says, IVO2 monitor.
Yeah, so for time's sake, pretty much what you said, right? Like cardiovascular causes, pulmonary causes. Most people are going to focus on those two. I think it's just important in situations to not forget about the other causes. For example, we've lately seen some couple of endocrine causes, right? That could be causing something like this. I think when you think about what would be the time factor into all this, right? Think about the time course. It could kind of rule certain things out, right? It's unlikely that a patient who has unless they've had a recent MI, are going to have an acute valvular cause as a cause of all this when they have not been having the current decompensations outside. Same thing with structural causes. Versus or even someone with just lung disease, right? They probably have had some progression of symptoms unless the cause of the acute lung injury is acute or recently started still a drug. So really when you think about cardiac causes, structural, electrical, valvular, or things around the heart. Pulmonary causes can be due to the airways, the actual alveoli, like water, pus, and blood, aka pulmonary edema, hemothorax, or pneumonia. And then all your rare vascular stuff, which is important to consider, right? I don't think we think about it right away, but if you are, for example, a pulmonologist, your base rate of disease for that specific diagnosis is going to be a lot higher than someone else, right? So if you're not making that diagnosis of, say, vasculitis a lot, the chances of you initially thinking about someone who has having vasculitis is likely to be low. Pulmonologists may think about ILD much quicker than a non-pulmonologist. a cardiologist, maybe thinking who's been having, been working within the cardiac ICU for a while, maybe just jumping to valvular causes, electrical causes, or structural causes for the heart and be ignoring the pulmonary causes. So you walk in, right? The first thing you're gonna do is ABCs, IVO2 monitor. Anything else that you want right away as you walk in?
Tell them to call X-ray because it takes a while to get there.
Yeah,
And then
sure.
grab the ultrasound.
Yeah, or maybe when you're heading to the room, the resident to grab the ultrasound first, so you can assess them right away using what protocol?
The blue.
Yeah. And so, initially your vitals, patient is slightly tachycardic. Their O2 is 88 on 30 liters and 80%. They didn't have any O2 requirements outpatient. They were found to be in the low 80s and they were admitted on 6 liters. Your focused ABC exam is that they are able to verbalize clearly, which means what?
Protecting the
Yeah. They're tachypneic, but not using any accessory muscles. The aorta lie flat without any symptoms. No evidence of JVD. They have some crackles that you hear. For those of you still using the stethoscope. And for this case, the scare, I did put the ultrasound pictures in. And they have some edema, which is chronic for the patient. So now, how does that kind of change your approach a little bit?
Seems less like volume overload, like pulmonary edema. There's no JVD. There's negative orthopnea, so less likely.
Yeah. You can obviously use an ultrasound to kind of confirm that, right?
Yeah.
What else?
I also keep things like PE on the differential, especially with the lower extremity swelling and the tachypnea.
Yeah, absolutely, right? All things that you can assess quickly at the bedside, right?
Pneumonia.
And so, what we do here is, seems like you have a good culture of everyone getting a blood gas. The patient already got a blood gas before you even walked in. One of you guys want to interpret that blood gas?
The Gulati.
Take it.
Looks like they're probably tachypnics with their breathing off the
Yeah.
state as well.
And you can obviously correct, for that level of hypercapnia, and you can see that it's all acute. You guys can do the table with the 1, 2, 3, 4, 1, 2, 3, 4.5, whatever. But it seems like it all falls in the acute spectrum if you decipher the equation. So if you, while talking to the patient, deciding what you want to do, you find out the patient has chest tightness that goes away with rest. It feels different than the angina that he's had in the past. And he does have a new dry cough. No fevers, chills, nausea, vomiting, or diarrhea. No night sweats or weight changes. These symptoms are usually classic for heart failure. He doesn't have. So anything significant stand out on this that I think will, I guess the next question is we talked about cardiac systems wise, right? What do you think is the inciting cause here? Or what might you want to do in this case next? EKG, right? And so EKG, I think will come later, but just shows sinus tachycardia. What else?
Have the ultrasound in as well for his heart.
Yeah, absolutely. So you end up taking him up to the ICU. He goes to the ICU just because of the dramatic increase in O2 requirements. Primary team is uncomfortable taking care of the patient. You are able to stabilize the patient on BiPAP. You put on 12 over 5 and 40%, you're overall fine. You get a little more history so that you buy yourself some time. The patient's past medical history is that he had an orthotropic heart transplant 6 years ago after having 1 year of a BiPAP. You guys know what those are? So orthotropic heart transplant is, back in the day we used to do heterotropic. Now you classically see orthotropic, which is, there's 2 types of heart transplants. One is when you just replace the entire recipient's heart with a donor heart, and a heterotropic heart transplant, which is also like a piggyback transplant. You leave the recipient's heart in place, and then you connect it to the donor's heart, to the right side of the chest, and it's overall pretty rare now, but it's advantageous in the sense that the new heart acts as an assistance to the existing heart, or if device complications occur, if you have a device in. And a BiVAD is basically a LVAD type device to help with both the right and left side of the heart. So he got the BiVAD 7 years ago. He's on these current meds. After you get a heart transplant, you obviously have to be on immunosuppressive therapy. His induction regimen was with basiliximab. Then he had immunosuppression with sirolimus and tacrolimus. And now he's on backroom for prophylaxis against.
So he has a BiVAD in place, or he had a BiVAD?
He had a BiVAD 7 years ago. His BiVAD is at the end of the day a bridge to a heart transplant. And so the backroom is prophylaxis against. Right? You guys know how sirolimus and all these maintenance meds work? Yeah. Yeah, I think this one's particularly like, so the way I remember it is like this 3 or 4 big ones you have to remember: sirolimus, everolimus, tacrolimus, and then there's just variants of that one. The newer ones are more expensive but less toxicities. So like, you know, the idea is to suppress your immune system from acting against your new heart. And why can't you just keep these patients on steroids? Because at the end of the day, these all agents are considered steroid-sparing agents. You get a lot of problems with steroids, right? Like loss in bone density, myopathies, things like that, right? So sirolimus and everolimus block the response of T cells and B cells from being activated by cytokines, which will progress like the cell cycle progression, versus like tacrolimus and cyclosporine, the production of cytokines. So obviously this is like, I think, pretty prominent change in the history. How does this change your approach to the patient now? What was the factor?
What was the factor for PCP?
Yeah, still. They go on prophylaxis, right, for immunocompromised patients.
Oh yeah.
You worry now about whether there's a component of rejection or whether he's severely immunocompromised, so potentially worse infections than you would expect in your normal patient population.
Good. So I think you're absolutely right. I think your overall suspicion of an infection goes significantly higher because of these settings of immunocompromised. So I think putting these patients on current antibiotics makes sense. What do you think you put them on?
Broad.
Yeah. So like, this is the idea of like, we talked about, sorry, go ahead.
I mean, like in general, you would go broad, but I'm trying to think what else you would cover for this guy that
Absolutely,
you would normally cover for. Probably keep him on the spectrum.
Yeah, potentially rely on your tending here, right? I mean,
Yeah.
are you going to be putting this patient on antifungal coverage?
For him, yeah, aspergillosis, you gotta cover invasive aspergillosis.
Yeah, I think that's a fair
I don't
bet,
know
right?
what happened, but like I know it's tacrolimus, sirolimus, you're immunocompromised, you gotta cover invasive aspergillosis.
Yeah.
And you have bacterial prophylaxis, you also probably should, and it's, if this guy, if this male gets intubated, you're gonna have to block him.
Yeah.
Make sure you let him put, go PAL for PCP, PJP, and then invasive aspergillosis or fundamental.
Yeah, absolutely, right? So we talked about the base rate of disease, right? What's important to realize is that even in these patients, you are still thinking of the diagram go. So if we talk about like cardiac and pulmonary symptoms, what's common is still common, meaning that this patient can still have heart failure, they can still have regular pneumonia with the usual bugs like streptococcus, viral causes, atypical causes, whatever, right? So you still need to cover that. And I agree in this patient, you still cover it, sorry?
What is DOE?
Dyspnea exertion. Dyspnea exertion. So like the reason it's, you know, what I like to do in this patient is like, in these cases, you have, you know, in patients on the floor, right? We're no longer managing patients on the floor, but patients on the floor usually have one problem with them, right? And you deal with that problem and that explains everything else. But the patients that we deal with, especially immunocompromised patients, it's like the idea of like Occam's razor versus Hickam dictum. It's like there's probably many things going on with the patient. And when you have someone complex like this, like you can do a mental challenge if you have the time. Most of the time you don't have time. It's like a Venn diagram type thing, right? Like take the differential of someone who has different exertions and someone who has like is immunocompromised, and then combine them and see what things could affect both. And then you start to really build up more specific differences. It's a good exercise to do when you have like 2 complaints that are very different or 2 risk factors that are very different. And then you combine them and you see what could explain both of them. And even then, it'll probably be more than one thing that's a problem.
Start broad.
So, you know, when you talk about what's common is common, we talk about that, but when you talk about like what could be happening because of immunosuppression, and one good approach is like, think about relapse, meaning that whatever the inciting cause for that heart transplant was, has come back. So it happens in the first heart, it can happen again, right? If it was like a vascular cause, that same vascular cause could be causing the second heart to fail. It could be rejection. It could be vasculopathy. So a lot of these patients suffer from chronic inflammation and very like micro-inflammation, and so that prone itself to vascular disease. And then obviously if it affects the kidneys, then that will also go into heart failure because of volume overload. And in the setting of immunosuppression, we're thinking of infections, and there's different types of infections. and your sequela of symptoms or your time course of symptoms may explain it, whether it's acute or chronic. And then other things to think about is like they're just on any other drugs, like drug-induced liver lung injury, like anemia is a very common cause. So the question you have to ask yourself is what's common, so common, am I addressing that? And then what else do I need to address for based on the fact that this patient has an immunocompromised history? And I think would be pretty much hit on the head, like, on how to approach it. So I guess other things to think about is like, are these patients more or less predisposed to coronary heart disease? Because one thing the patient did says is that the chest pain that he's having does abate with rest, but it's not like his classic anginal symptoms. Why do you think that is?
Was his classic anginal symptoms before he had a new heart?
Yeah.
It's a different heart.
Yeah, and so what we have to realize is that like patients that get heart transplants, if they were predisposed to coronary artery disease before, that risk doesn't go away. If anything, because of having a new organ is going to breed inflammation. Inflammation breeds clotting. They are more predisposed to coronary artery disease after getting a new heart. But why might he not present with the classic anginal symptoms?
Surgery is going to cause harm to the nerves that are there.
Yeah, obviously these patients undergo vagotomies, right? So that vagal nerve being gone, they're not able to present with the same classic anginal symptoms. Symptomatic burden-wise, it might be the same. Like they may get additional exertion, like in this case, but you still rely on the same thing, troponins and EKG. Just keep in mind that troponins might just be elevated because of inflammation to the heart. You can kind of rule out a lot of the other stuff. What infections are you guys concerned about in a post-transplant patient? Yeah, so like EBV, CMV are big ones to think about. So important questions to ask this patient is their donor history. You guys should be asking them about all your transplant patient is, the way you can simplify it is like, do you know if your donor had EBV or CMV? Did you have EBV or CMV prior to transplant? Because they would have been tested for it. And then were there any infectious complications after you got your transplant? This patient is 6 years out, right? So they probably dealt with these issues in the year or so after. EBV commonly is a problem in the first year after diagnosis. We talked about during board review that the way they'll present is lymphomas. Anyone know why? So what will end up happening is that you put on high dose immunosuppression, right? Especially in that first year afterwards. So you completely suppress your T cells. What will end up happening is allow your B cells to grow. Exposure to EBV heightens that B cell proliferation, and that's how you get your B cell lymphomas. So the EBV proliferating B cells plus T cell suppression predisposes you to lymphomas. Very common in that first year afterwards. CMV, you usually get like diffuse pneumonitis, and then obviously you start to consider your other usual respiratory causes. Why am I not as concerned about maybe a bacterial infection in this patient? You can still, so atypical bugs, you can still present with dry cough. In this patient, he had a dry cough, right? So you usually, think about like bacterial pneumonias usually present as a consolidative process due to pus filling in the alveolar line, and that causes a lot of productive sputum, which this patient didn't have. And so, yeah, once again, and then the other thing to ask about is like hospitalization since their transplant. If they're having recurrent hospitalizations, you're going to get a suspicion about a viral cause, much likely to be higher, as well as vascular causes. Social history obviously important, not as relevant here, but sure, patient's pretty sick, you're less worried about that, I get it. But I think this information helps kind of rule out a obstructive cause because he hasn't been smoking for a while. And then obviously, this is like a very remarkable history that I don't think many of us are going to be getting to this day. But what does it help you rule out? If you guys are still practicing with like Dr. Kaufman, who we all like respect a lot, he's an IV doctor that always spent a lot of time in the ICU, would help us pick out the infectious cause before we even had culture data back. Meaning we have a good idea of what the organism is on day one versus waiting the 2 or 3 days. And he was usually pretty right all the times, pretty much all the time. Yeah. What do you think? What does this help you rule out?
Rule out, like, it's like you guys see cocci.
Yeah, absolutely. Right.
Those like bacteria that are or fungi that are other
I think one thing that you guys are supposed to be studying on your boards, I don't know if you guys still do, but like there's zoonotic infections, zoonotic infections. So infections that are carried by animals, important to consider, which in this case, like deer hunting, having a dog at home.
Okay.
She said, hey, to the dog.
You said rule out, right? So you're not like, those are like Campylobacter.
Yeah, I think just to think about, right? And so I think most of your antibiotics should cover that, right? And maybe having very coverage, even like something like in a community-acquired person that may not be compromised, something like levo or ceftriaxone, those should be fine for the majority of these zoonotic infections. All right, so we said we wanted an EKG, chest X-ray, what else? Patients unstable for
I'm gonna get an
CT right
echo
now.
and consult cardio.
So we didn't get an echo.
We could do CT chest at this point.
So, I mean, in case labs are important, probably it's important for us to really get as much. But yeah, I mean, I think nothing else really going on. Important to get levels, right? His tachycardia level was 10.4, his thyroid level was also like 14. His echo overall, you expect to see some changes, but the best way to actually see whether the heart is a problem is a stress test, which I don't think the patient's a good candidate for right now. But he did have one done outpatient not too long ago at the spine. You guys know your level goals? 4 to 8 for tacro, and then Cyro is really dependent on whether you're on a single or double agent. It's really specific and it's determined by the treatment center or the person managing outpatient. But it's usually where between 10 to 12, or sometimes people, if you're on a single agent, is higher than 12 to 18. But he's on a double agent. I think for tacro it's 6 to 8. Like for 6 months, 10 to 15, and then after that it goes down. But it's very like individualized.
Depends on what organ.
Yeah, and the organ, yeah. Levels have to be monitored. Thoughts? They want some imaging, right? EKG,
Let's go from here.
I mean, yeah, sure, we can get it another time. So really, your criteria for sinus tachycardia, it means all 5. If you don't know your criteria for sinus tachycardia, stick around, we'll go through it. Chest X-ray. I guess good.
No, I mean, in general, like, do you want me to go through it?
Let's do the 2-liner.
Okay, I mean, it looks like there's maybe some interstitial, increased interstitial markings on the right side.
Yeah.
Maybe a little bit on the left too, more so on the right side, maybe, and can infiltrate there. But other than that, very unremarkable. On the upper lung lobes too, perhaps. But I see it more so on the right, lower, next to the cardiac left there.
Yeah.
Yeah, I agree. There are some markings actually in the right upper lobe too.
Yeah.
But you see prominence in the right lower lobe, and then probably you could say right middle, but we don't have clear lateral ones.
Yeah, and you can go through the whole process, but honestly, I think this X-ray is informative in helping rule out things, right? It's by the absence of
Large effusion.
Like a low bar.
Yeah, exactly. So you can rule out a lot of those things, right? I think based on this X-ray, you can essentially, you see a lot of like reticular patterns, which could be early effusion or early permadema, right? Like if you zoom in, maybe you can see that those curly V lines, where you're seeing like an infiltrative process, or not infiltrative, or reticular pattern. You're not seeing oral effusions, you're not seeing like a pneumothorax, you're not seeing overt lobar consolidations, right? Which is helping you rule out a lot of things. So it's more helpful in the absence of what's not there than what is there. What is going to help you? CT, oral, so when you're having this case, and the patient had more workup breathing, more accessory muscle use, they were sustained to get in the 50s. So a decision was made with the patient to put them on the ventilator. They were stabilized in the low 90s on a peak of 10 and 60%. And now your patient is now slightly more stable for a CT. Obviously, one image does not do any justice to your diagnosis. But if I said that this cut was more than enough to help you make your diagnosis, how would you guys interpret it? I know it's difficult without everything else there. Just one cut is useless in a CT. But what can you tell? And approach it the same way. By the absence of what's not there, then what is there? Say the rest of the X-ray, a CT looked like this.
It's not very remarkable. I mean, if, I don't know, we're seeing some, let's.
We're seeing some things that can't read.
So basically, lots of dots and dashes, right?
What did you say?
Dots and dashes. That's where I see it. Dots and dashes.
Yeah.
You guys heard that term before?
No.
No?
No.
Bronchiolitis, dots and dashes.
I've heard of bronchiolitis. but not
Yeah.
dots.
And so that dots and dashes pattern where basically what you see is like a bunch of ground glass passages around a bunch of lighting up, dots and dashes, meaning your alveoli and your bronchioles. It's inflammation in those areas, aka at the very distal areas of your airway, bronchiolitis. And it's usually associated with some infectious causes, some drug-induced causes, but something that's causing inflammation. And usually these processes are more acute than chronic. All this like gray stuff that you see around is interstitial thickening. You guys know what the physiology of ground glass opacities are? So ground glass opacities is pretty much like, which is what this grayness is. So when you guys see an alveoli, and you see pulmonary edema, right? It looks white, right? Or when you see pneumonia, it looks white. So this is what's happening in the alveoli. It's filled with fluid, water plus with blood. When you see this, with some air and some white, wow, instead of being black or instead of being white, it's gray, right? So you're getting early filling up of fluid, which is just very clinically evident of inflammation. And that's how you get this ground glass opacities. And that's what causes that interstitial thickening. Because you're getting filling up of your veins and your lymphatic vessels. And so you're thinking infection, you're thinking something inflammatory, maybe not, obviously you don't see any cavities, you don't see any structural disease, you're not concerned about things like emphysema and all that, plus any of that would be more chronic anyway. This seems to be happened a lot more acutely. And so we still don't have a clear diagnosis, right? And when the diagnosis is the issue, get some tissue, right? And so what do you want to do? When you do the bronch, what kind of stuff do you want to get?
Yeah.
What are you going to want?
Because you get one chance at this.
You're definitely going to do a BL, 100%. But what are you going to do with that information of BL? You're not going to write BL.
Oh, no, you mean what specific?
Yeah, what specific stuff do you want to send? You did
Because you're doing the bronch, so you have to
you did a
order.
great 120 mil equivalent, like aliquot. You cleaned it up. You went to the right lower lobe because that's what you're concerned about, right? Or right upper lobe, probably even go for right upper lobe. Did the aliquots, cleaned it up. You got your BL. What do you want to check?
Do a Gram-stain culture, soft count, glucose. We will do a pH. You could do that too. You could test for eosinophils if you want, but it depends on how much you got from the BAL. You should also do Sundial that we mentioned already. Send it off for PJP as well. Specifically from there, I don't know what I'll order of all. Anything else?
That's everything I was thinking.
We're clearly missing more because neither of them.
So, yes.
I don't know if you can beta glucan or not.
Yeah, you can get it. Yeah, it's actually better with BAL.
What did you say?
Beta glucan.
Oh, yeah, baby. What, that is French tongue.
What?
Beta
Glucan.
Yeah.
Yeah.
That's what you're, that's what 130 beta glucan is. You can send like aspergillosis specific stuff. Yeah, so aspergillosis stuff. And then leave a status for the core. I mean, that would be good.
I don't think so. I mean, I think that's a very good idea to have. Test
No, you send it, it's an order.
Yeah,
They
yeah.
send it to new core labs, you're gonna go because it might be good. But so that, and then I would probably even, you don't have, you can send ADA, adenosine,
Yeah.
ADAMS, whatever that is.
Yeah,
That's what it's called.
5 minutes.
But the main focus should be invasive aspergillosis, or basic stuff. Like you still have to, at the end of the day, still, I know you're not seeing any low volume salvation rates, but you still have to do that. Inflammatory stuff, I think, so it sounds pretty acute, it didn't happen over a long period of time. You know, every time you have inflammatory gram-glass opacity, one of the diagnoses that everybody talks about is cryptogenic, like organizing pneumonia.
Yeah.
But usually that's when you don't have an answer or it's a chronic process. There is a form of acute version of it too that responds to steroids pretty significantly. So you can check the differential, the CDC differential, and the gram stain and all of the work of the thing is you also want to make sure when you do aliquots, you do not see any DH. I don't think so. There's any like blood because you also want to make sure it's not inflammatory from something else. I think that's pretty much covered all of it.
Yeah, and that's going to help you basically differentiate between what you find. Is it going to be what's causing the inflammation, an infectious or non-infectious cause? And that will also help you guide your treatment, right? So CT was done, or BA Rock was done. You got thin non-virulent secretions, 120 nucleated cells, 42% polymorphic neutrophils, 41% lymphocytes, 10% EOs. You obviously sent your BA for all the stuff. A lot of it was negative. The cultures eventually did grow Bordetella brachyceptica. You couldn't get to EBV or CMV. Any idea why? We couldn't get to EBV or CMV. Any idea why?
We typically test that on a BAL.
You can't. Yeah, it has to be by biopsy.
You gotta get tissue biopsy.
Yeah. But
Do you have a dominant?
yeah. And so. So yes, the patient does have a dog. LV was normal, so it's like the EGP.
I'm just kidding, because there was talked about putting hard stuff on dogs.
Yeah. So yeah, Bordetella brachyceptica.
Cardia is good. Then you gotta get a cardia.
Yeah.
But usually, if you see a cardia, you see it within
Brain abscess.
brain. So it's so long brain. So it's three systems that are affecting, right? But usually, cardia is also seen early in the course.
Liver, brain, and some around the
Yeah, so usually brain is the main one, and then you see those angles, but they're not the same thing as the aspergillus one.
Yeah. They're great.
Not the actinomyces one, but the cardia is the one that is like less angled.
So this patient was initially diagnosed with mechanical, right? Like Bordetella brachyceptica, usually seen in dogs, usually affects patients if they're immunocompromised, but usually otherwise, like we'll just have it there and they won't get affected by it. Maybe a cough. A lot of the case studies have been reported in HIV patients because they're obviously immunocompromised. And it can range anywhere from like a mild upper respiratory tract infection to really bad pneumonia. And obviously this patient had dogs. So, but the problem is like this patient was put on appropriate antibiotics, right? And when it comes to cultural sensitivities, he didn't respond. He kept getting worse. So the authors of this case, and including the Hearts campus that it was sent to, didn't feel that this was the cause. What else stands out on your BAL?
Eosinophils?
Yeah, and so based on that, they were suspecting less likely an infectious cause and something else would be.
Hypersensitivity.
So why did we say like when we did the BA, why was that like you gotta get like the differential?
Yeah. Typically, if you're sending for eosinophils, you have to send. Oh, that's why you said the 120. Because
You
it is a
gotta do
volume.
it with BL.
Yeah.
So
If you do aliquot or something.
yeah, so that's what
Yeah.
I'm saying. So
Yeah.
that's why I kept saying like 120 milligrams. So if you're gonna say I'm committing to a BL,
Yeah.
you better commit to a BL. Don't toss me a BL with a 20 cc. It's not a BL.
You guys have seen the things, right? They're huge. Yeah.
Yeah, but you gotta do washouts, 60 washout, and then some pulmonologists, we actually did one on overnight on an immunocompromised patient, it's a candidate. And did 120, and then ended up doing a BL.
Your tissue yield is going to be poor if you don't do it correctly, if you don't get just the right specimen. It's like trying to find a needle in a haystack, but with high volume aliquots, you can get it. I would usually call the lab. I know some of the pulmonologists do. They still call and say they want everything analyzed. So all it takes is one. Everything else will be either too early or too late from the sample that you needed to get. So the people taking care of this case, basically Cinephel's diagnosed this as likely sirolimus-induced pneumonitis, which can present very acutely. We use it for immune suppression, we talked about it, but a lot of good case studies.
On it for 6 years, it can still present acutely.
Yeah, his levels of super therapeutic. Is at 14 compared to what he had been on. And so it's a form of interstitial pneumonitis, usually seen in transplant patients, usually not seen right away, usually seen after a prolonged course, and it explains the bronchiolitis that you're seeing. Yes, it is a diagnosis of exclusion. In this case, they clinically said that he was put on appropriate antibiotics and wasn't responding, so it might have been something else. In this case, they did put him on steroids. But your primary treatment here is to stop the agent. They held him off on sirolimus, and with the stick combination of steroids, he was able to be extubated, had a prolonged pulmonary recovery. In discussion with the transplant team, they decided to keep him off sirolimus. That's not your choice to make, it's theirs. And so I would call every time. One of the reasons why we don't use it anymore because of the toxicities, primarily a lot of renal. But in this case, obviously very appropriate to hold this agent, something that you should definitely consider when you're seeing a patient like this. So, it was discontinued. He was all discussed with the cardiac transplant center. He was extubated to rehab. And then after holding sirolimus, got serial CTs, which some studies do, and some people will still recommend, you'll see improvement in your lung injury afterwards.
Also, that's steroids, right?
Yeah. So it's like the combination of steroids plus holding sirolimus, right? And so this is why it's so important with the patients that we see. And if you take one thing away, it's this: is that figure out what your diagnosis is, right? And when you don't have an answer, fight for that answer. Because here the key was differentiating between infection and non-infectious cause, right? And it took a multidisciplinary approach that even though they had positive cultures, say, why is this guy not responding? And so they took him off. They put, if it's the infection, you probably don't want to do steroids. If you think that the infection is the cause of the agent, if the cause of the problem, he's not presenting like an ARDS patient, right? PEEP requirements aren't that high. CT findings aren't similar to that. You should be responding to antibiotics. And so, yeah, and there's all this criteria of like sirolimus-induced toxicities. What I would recommend doing pros-wise is when you see patients like this, go through their full drug history. There's a website called PalmTox. It'll go through every drug that you're on that can cause pulmonary toxicity and what their CT findings would be. And you really sit there and go through their findings with the findings that I mentioned on PalmTox and see if it correlates or not. And make sure you discontinue that agent, because until you don't discontinue that agent, they don't have a chance of improving. I'll share this slide with you guys so you can see it, but like your best friend here is high-risk CTs. If you were to get it, discontinue the agent, consideration of steroids, which usually has been associated with like quick improvement. But if there's one thing you take away is to consider the diagnosis and look for it. When you don't have an answer, we'll get some tissue. Questions?
What's the name of that website again? PalmTox?
Yeah, sorry, Pneumotox. Pneumotox or PalmTox, one or the other. Yeah, and then you have like basically, you just go through and start entering the drugs and tell you what the chances are, what the CT findings are going to be like, what the other syndromes are. Yeah, one for the liver too. All right, cool. Thanks, everyone.
I'm just going to AI. I like it.